The first case I am going to discuss, female 68, non-smoker, non-diabetic, non-neuropathy. What do you think, sir? Anybody from the audience volunteer? Chairman, sir. Okay, sir. Anybody from the audience? Do you need any more? The posterior malar fracture you are thinking. I am giving you the vortex view. Does it change your plan? Lateral malleolus. The lateral malleolus fracture. You are right, absolutely right. But now, what is the next? Non-operative or operative? And why? Anybody for operative? Anybody for non-operative? For non-operative first. Non-operative. Why do you want non-operative? Why do you choose non-operative? Anybody for operative? Why? Reason? To correct the subluxation. Okay, you see the subluxation here. Okay. Patient, surgeon choose to do a non-operative treatment. Is it okay now? Do you feel it is okay? Hello? Do you feel it is okay now? Anybody want to comment? Here. Is it okay? You are a spine surgeon, but basically general orthopedic surgeon. Yes, sir. Sir, do you want to comment? Surgeon has chosen to do a conservative treatment. He has plastered. Do you feel anything abnormal here?
I would like to take a CT scan.
CT scan. Okay. Before CT scan, and anything easy than a CT scan?
It's laterally subluxed.
It is laterally subluxed. You said. You said.
Sir.
So, patient had a constant pain. Patient had a constant pain. So, this is the gravity stress view, and this is the gravity stress view. So, one has to think about the dynamic stability, unseen plane, the third plane. Always check for the instability. Static X-rays may not tell you exactly what the situation of the soft tissue and the ligament. That is the message. It was fixed like this. Okay. Another patient, male 28, history of pain while getting down on the staircase. He has a pain till 12 weeks. Weight bearing X-ray shows this. So always go for a dynamic view. And you can see the flag of the tissue here. There was a syndesmotic injury. So always get a stress view. Never depend on a static X-ray. That is the message. Another case, female 59, active physiologically, no comorbidity. In emergency, this was reduced in emergency and posted for an elective fixation. And surgeon has done elective fixation. Is it acceptable, sir? Fixation has been done now. You are the surgeon. What do you suggest on table?
Syndesmotic joint is not fixed.
Syndesmotic joint is not fixed. So, it may not have been stabilized. So always big no, always check with the hook test for the instability. It has to be checked in anteroposterior and the mediolateral direction. So that is the message. Syndesmosis was fixed after reduction with the pointed clamp, and this is the follow-up. Surgeon has placed the clamp here to reduce this syndesmotic. Is it okay? What is your opinion? Do you want to opine, sir? It's okay. The clamp he has put is okay. The question here, pointed question is the pointed clamp.
Yeah, I think it's okay.
It's okay. Okay. No, it's not okay. See, if you put a clamp like this, if you see the clamp is on the anterior side, not on the ridge, and here it is on the ridge. What happens exactly? If you put a clamp anteriorly, this will get mal-reduced. If you put a clamp posteriorly, it will get mal-reduced. So this is again a red flag. There is a very good paper, iatrogenic syndesmotic mal-reduction via clamp. You are doing iatrogenic mal-reduction. This should be the placement of the clamp idea. On top of the clamp should be on the medial ridge, and here on the lateral medial ridge, and this should be the direction. So that is the message I want to give. This is the paper, this is the literature available in the Journal of Bone and Joint Surgery. Now, anybody want to suggest. Surgeon has fixed the syndesmotic like this. Do you want to say something? Is it okay?
Yes, sir.
It is okay. Do you feel anything suspicious here? I want to make little interactive. Do you feel?
It's not okay.
Why it is not okay? What do you feel? Which part is not okay?
Yeah, posterior malleus is not.
Yes, absolutely correct. If you see here, there is a small flap of the posterior malleolus that is giving the instability. It is not the size of the posterior malleolus, it is the instability with the ligament that is very important, and it has failed like this. So, whenever there is a posterior malleolus, it is also the syndesmotic injury. So the malreduction of the posterior malleolus, it is equal to malreduction of the syndesmotic joint. So always take care of posterior malleolus. And there is a very good paper that well reduced and fixed posterior malleolus, many times they obviate the need of syndesmotic fixation. This is the paper. So whatever the method you use, the most important predictor for a result for syndesmotic injury is the reduction and 32% we are wrong always on IRTB. Even if you do an IRTB and check multiple, you have to have a CR, that CT scan in the room, or you have to open up and check. So reduction is the most important predictor, and 1 mm displacement bar mechanically leads to less than 42% tibial contact and arthritis on the long term. So this is very, very important to prevent the arthritis in the ankle. Surgeon has chosen to put the screw from anterior to posterior here. It's a red flag. I was also doing previously, I was wrong. So this is the message I want to give. If you read this paper, always go for the CT scan. What is the pathoanatomy of this posterior malleolus? The posterior malleolus presents in a different way. So you always check for this, and this is a very good paper of pathoanatomy by Haraguchi. So go for this paper and always have a plate, buttress plate fixation. So the message is the size of the posterior malleolus does not matter. What matters is the instability. What is the instability? That does matter. That is the present situation. Previously we were thinking that less than 25% is not required to be fixed. It is the instability which is more important than the size of the posterior malleolus. Malalignment of the fibula leads to arthrosis. Length and rotation of the fibula is most important, and we know this. But the peculiar problem for the surgeon is intraoperative. We can see on the X-ray that it's normal, there is a certain axial rotation. The problem, can we recognize this? Rotation of fibula on IRTB image during the surgery. Anybody has an answer? There is a very good paper here where you can exactly see what is the shape of the fibula. You have to draw the line of the fibula and get the shape of the fibula, and if normal shape is just like a spatula, and if it is externally rotated, it will look like a blade, and if it is internally rotated, it will look like a spoon. So there is a very good paper. Many times it becomes very difficult on table to decide whether I have fixed the fibula in right rotation or not. Length is not a problem, rotation is a problem. Another red flag. Can you recognize any red flag here? Sir, can you ask me? Can I ask you? Any red flag you feel here? Anything abnormal? I want to involve the audience, that's why. I am taking your permission. Do you feel anything abnormal here? Any extra care you would like to take? It is the lateral malleolus, it is the medial malleolus. Clear? There is a possibility of the posterior malleolus that he is saying on the X-ray, right? But there is no posterior malleolus here.
It looks resorptive.
Resorptive. It is resorptive. It is a vertical fracture line with impaction. So, particularly in elderly with osteoporotic fracture, always have high index of suspicion This needs a small buttress plate because the fracture line is vertical. You will not be able to do with the tension plate wire. You need a support. There is a crushing of the bone, so you may need a bone graft. Always go for the CT scan to see the crumpling of the bone here, and you may need some bone graft here, and you have to elevate that part. Another part is the elderly osteoporotic. Routine mode of fixation is like this, and many times we fail with the routine mode of fixation. So particularly,
Sir, time is given, then the unscheduled is there. Kindly completing the
I have to complete the
2
time,
minutes.
sir. 2 minutes are remaining.
And the request from the audience.
Yes, sir. You have to have an augmented mode of the fixation with the osteoporotic bones, like intramedullary fixation and the plate both. Another is the talus fracture. Is undisplaced. It looks undisplaced, not a much soft tissue injury. Minimally invasive surgery, surgeon choose to make a minimally invasive surgery. But you have to go for the CT scan and you can see there is a rotation and a malunion. So reduction is the priority, but there is a problem always. You have to get the CT scan before you start for the talus, because many times on the X-ray you do not judge the rotation and the mal reduction is the problem. This is the paper. Delay in the treatment does not increase the chances of the LVN. 81 talus. Trajectory of the screw is very, very important for the talus. Equator of the talus has to be taken care of, otherwise there will be dorsiflexion and malunion. 2 screws, 1 screw in the compression, 1 is the static, that has to be there. These are the literature of the mal reduction with the talus where you are not taking care of. And this is for the pylon fracture. I am completing, sir. When there is a red means stop. And handle with the care this envelope. Soft tissue gives you more trouble than the fracture in the pylon. This is the literature until you get this. Another literature is understand the soft tissue interposition. Ask for your radiologist to get the window for the CT scan. And there is a 10% possibility of interposition of the soft tissue. After clearing interposition, this is the picture. So all the fractures around the ankle are not same. There is a wide spectrum and there is a moderate agreement. So think dynamic stability, unseen plane, third plane. And there is understanding of the mechanical, biological and clinical interplay. Thank you very much for your kind listening, sir. And I have
Healing of the syndesmosis is not known to the orthopedic surgeons of the nation and international. There, because of the healing power and the complications are much more heavier, rather than whatever you fix with the plate, you fix with a screw, you fix with a plaster. The syndesmosis, the normal anatomy, it is a fibrocartilaginous joint. The healing of the fibrocartilaginous joint is not yet known to the world. Thereby, there are problems are coming with this, the syndesmosis problems. They are called as the syndesmosis problem. Either you fix with a plate, you fix with a screw, or you fix with a very classical plaster technique, or you just there may be interposition of some soft tissue is there or not, or the healing power of the cartilage is fibrocartilage is not yet known to the world. Thereby, there is a difficulty in the syndesmosis fracture. Is my opinion. The paper is open for the discussion.
Small piece, excuse me, that small piece which you are,
yeah.
can you put a small screw there, that small piece, that detached ligament between the,
You are talking about the posterior malleolar fracture?
that one also, and one more.
Syndesmotic injury?
Yeah, syndesmotic.
That was indicating that there is a ligament injury. That was a small flag is a sign of ligament injury, avulsion injury. So you have to look for that. That was the message.
Thank you.
Thank you, sir.
Here we are, thanks for the chairperson Dr. Ashwin for giving the chairing the session, and we are very happy to chair this session. But with the very close friend, that is the Dr. Gurudat, my teacher's son. Most of the time thanks for the Ashwin and the KOA group for giving the chair session.
Thank you, sir. Now I request the chairperson to give the memento certificate to Dr. Naveen Thakkar. Now I request Dr. Srinivas sir to give the memento for the chairperson. Dr. Thank you.
Dr. Ashwini Kumar Singh, Organizing Chairman, KOACON 2020, to chair the session. I request Dr. Shashi Reddy, Organizing Secretary, KOACON 2020, to accompany Dr. Shantaram Shetty sir to the dais. Now I request Dr. Ashwini Kumar Singh to introduce the orator, Dr. Shantaram Shetty sir. I request Dr. Shetty sir to give bouquet to Dr. Shantaram Shetty sir.
Well, good morning everyone. I think we are here for the most awaited session, that is the oration of today's oration. Okay, Dr. Shantaram Shetty sir doesn't need any introduction. All of you know him very well, but nevertheless it is my duty to introduce him to audience. Okay. Professor Shantaram Shetty has done his MBBS from Mysore Medical College in the year 1964. When he finished his MS in 1969, he did the first years from England, Medical College as well as Royal College. He is a fellow. He was a former professor and HOD of KMC Mangalore for 26 years. So he was a Dean of KS Medical College for 8 years. He was Vice Chancellor of Nitte University for 4 years. He is now a present Pro Chancellor of Nitte University. He is an AO trustee for nearly 6 years. He is the first AO Indian Council Chairman, and he has about more than 82 publications and 180 presentations till date and more than 17 orations. And he has trained more than 300 PGs till now. And he was a former IOA president in the year 2009. He was our own president in the year 1980. He was a KOACON president in the 1984. And with this lot many to tell, I think I introduce the Shantaram Shetty to the audience. It's my pleasure, sir. Yes, please.
Dr. Ashwin, Secretary General Dr. Roshan, fellow colleagues, delegates, ladies and gentlemen, I consider it indeed a privilege to have been asked to deliver this very important oration of our Karnataka Orthopedic Association. My theme today is Karmanye Vadikaraste Mapaleshu Katachana. I bring you greetings from my own university, Nitte University, which is 8-year-old and it is ranked 70th out of the 900 universities in our country. And my own private institution, Tejaswini Hospital, which is a DNB accredited hospital. Do your duty and leave the rest to God. thank our President Dr. Kamreddy and the organizing committee of KOA, headed by Dr. Ashwin, for bestowing this unique honor to me. Dr. Shamsundar was a very close friend of mine. Born in 1936 in Mundpur village, he came from a family of landlords who lost all land due to land reforms in 1972. He had early schooling in Mangalore and joined MBBS in Kaynes, Hubli, and completed it in 1963 and worked as a tutor in Goa Medical College. He did his MSR from Rohtak Medical College under Dr. Mani, a legend in orthopedics, as you know about this thing, index. And after MSR, he came into Goa Medical College, and in 1969 he started the Department of Orthopedics in JJM Medical College, Davangere. Worked in various capacities at JJMS, and he was a rare blend of an excellent teacher, a brilliant surgeon and an able administrator. More than all gentlemen, he was a friend, a guide and a philosopher to many. And here are some of the photographs which I could lay my hands upon with Professor Mani as a young professor as he was with Shamsundar, and with Satyendra Rao, as you see, when he was the president of KOA, and with all his colleagues there. And here was Satyendra Rao when Shamsundar was the president of KOA. He was a perfect family man, and he founded the city hospital, city medical center at Davangere. His wife, Mrs. Sharda, whom all of us know, was professor and head of the department of obstetrics in the same college. He is blessed with two children, Dr. Sana, who is a gynecologist, and Dr. Subodh. I do not know whether he is here. He is now the professor of orthopedics in JJMC, and he is continuing his great traditions of his father. Gentleman Shamsundar was a honest, upright and tenacious in his purpose. People like Shamsundar Shetty will always be remembered by his patients, his colleagues and society at large. He has left behind his footsteps in the sands of time for people to remember and emulate. We are here in this beautiful township of Ballari, Dr. Ashwin, and with the Hampi as a heritage city. This beautiful city of our country is unique, not only because of its serenity, not only because of natural beauty and a city which has given to the world the Vijayanagara Empire and heritage, which I feel is much more important even than the Roman Empire or even the Egyptian Empire, which can never be erased. Medically, it has one of the best medical schools as Ballari Medical College with excellent orthopedic colleagues. It was rather difficult to select a subject which befits the name of Dr. Shamsundar and Ballari in particular. And I have chosen this subject which will mainly discuss cases and basic principles which Dr. Shamsundar Shetty followed, preached and practiced. Mahabharata to me is the greatest of epics of all mankind. It has dealt with the philosophy of life. It has dealt what is right and wrong, and it has dealt with what is good and bad. That was the philosophy of Dr. Shamsundar Shetty. Karmande vadikaraste mapaleshu katacha. Do your duty first and leave the rest to God. Do no harm if you cannot do any good. Come to the Bible. What does it say? Why am I here? And what is really important is to do good and do no harm. What does the sacred Quran say? Spirituality, the moral righteousness in whatever you do and do good to others. And whether it is Bible, whether it is Gita, or whether it is Quran, it predicts the same. The whole philosophy of Gita, Bible and Quran, gentlemen, is the primum non nocere is a Latin word which says first do no harm. Non-maleficence is one of the principal perceptions of bioethics. Dr. Shamsundar firmly stood behind these great words. With the biotechnological pursuits which we discussed for the last 2 days here, and better understanding of tissue healing, imaging, transplantations, keyhole surgeries, nanotechnology, navigation, robotic systems, tissue engineering and stem cell technology, and gene modulation and therapy and artificial intelligence, the next 2 decades for the surgeon to you and me and to the future generation. The teacher, the student and to the patient will be perhaps the most fascinating period in the history of mankind and the history of medicine. But unfortunately what we see today is that every nailer, a hammer and a nail is inside. And for an orthoplasty surgeon, every hip is an indication for replacement. Locking plates are fixed without an indication, and scopes are introduced into the joints whether indicated or not. But we should remember there is a patient with a heart and a soul, a family, and 30% of our patients in our country who cannot afford even a square meal. With the super specialties having crept into our specialty, which of course is a necessity, but unfortunately every fractured bone is fixed today. Every backache is explored and the patients are pounded with antibiotics, analgesics, and much to the benefit of pharmaceutical companies, but to the agony of our patients. The conservative line of treatment was the mainstay in the treatment of fractures in the history of mankind. Today, in the name of life is movement, and movement is life, which I professed at the university. Every fracture is being read with a nail or a plate. We forget the biology and think of the mechanics, and not both as a tissue, but as a tool. To be successful, gentlemen, in orthopedic surgery, basic mechanical aspects of internal fixation of fractures can never be eclipsed by new fixation devices. In treatment of fractures and diseases of bone, a surgeon should be a gardener and not a carpenter. Of course, we are not angels. In the next 18 minutes, I'll be dealing with how sometimes we can be instrumental in the morbidity and the mortality of patients, and can sometimes do more harm than good to the patient. No doubt, each one of us undertake our surgery or daily work with divinity, but we can to a large extent prevent complications, and even if it has happened, it should be corrected on time so that further misery to the patient is avoided. Especially in a country like ours, where every second there is an accident, killing 17 people every hour and injuring thousands of patients, resulting in considerable morbidity. India, gentlemen, is also aging and sports-minded, and with the increase of arthroplasties and arthroscopic surgeries, India is also a capital, mind you, for diabetes and cardiac diseases. Where infrastructure facilities are a liability, trained personnel is an added problem, and a huge number of patients coupled with greed both by the surgeon and the corporate world. A mistake done in the first 6 hours to 24 hours and not corrected can be a disaster to the patient, hence should be rectified at the earliest, preferably by the same surgeon. Do not wait for a morrow, especially for a tomorrow. I feel the patient and the relatives are confused today. So a team of doctors in every hospital should plan the treatment and execute it to perfection. If a patient requires a better care, as per the latest evidence, he should be given that particular choice. Look into each one of these patients and watch it carefully. Here is the intercondylar fracture fixed like that. And here is a patellar fracture where the screw is inside into the joint, not removed for nearly 1 year. Here is a distal ankle which we discussed just now, fixed like this. And imagine a transverse fracture of the acetabulum fixed this way. And it remained like that for 4 to 6 months. Even Gerard Kuncher will turn in his grave, look into his nails being misused and overused into this nature. Look into the nail which is propping out. Look into the nail where the entry point is completely wrong. Look into the nail where it has propped itself into the joint. Look into each one of these plates where it was not indicated at all, and it has been misused and underused. A small plate being used for fixing the distal end of the tibia, a reconstruction plate. Look into these K-wires which are used for a supracondylar fracture. And look into this intertrochanteric fracture which is so not reduced at all and fixed. And look into the right side picture. I do not know how the surgeon came out of the theatre, coming out with this particular picture of the fracture of the femur, where the nail was not in the medullary cavity at all. And this was kept for 1.5 months before he came into another center. And look into the AP view of this DHS, and in a lateral view it is completely out. So it is so important that we correct whatever follies we undertake in our everyday life, correct it immediately and not. And look into this patient came to us with this particular picture, where a PFN, where you see that nail which is propping out like that, and it was kept like that. And we tried to correct it. Unfortunately, the patient died of pulmonary embolism on the 3rd day. And this can happen to any one of us. And this is look into the arthroscopy with a huge abscess in the knee joint. And look into these fixations, these replacements of the knee and the hip being done this way. And this was kept on for 2 or 3 or 4 weeks till the patient came to the next surgeon. And any one of us can face this every day, and this should not happen. Look into these are unimaginable types of internal fixations done. Look into the plate being used for a fracture shaft of the femur. And look into the cavers which is fixed for a trochanteric fracture. And even Bhishma's Saralamancha would never have had so many arrows to stabilize his sleeping cot. And look into the trochanteric fracture being fixed with the cavers as you see there. Gentlemen, let us start with case studies. One of the commonest fractures which is inserted every day is the fracture shaft of the humerus. And we have traveled from bamboo springs to hanging cars, from hanging cars to functional braces to compression plates, to close interlocking nails to MIPO LC plates today. And look into these statistics, whether it is hanging cars, compression AVO plates, or locking nails or locking plates. It varies from 94 to 97 to 98 and 97%. You can bring about same result in whatever method you can. It varies from 94 to 97%. And look into this transverse fracture. Many of us immediately will try to fix it, yes, but look into this particular patient in just about 3 months, just with 3,000 rupees, the fracture is united very well without any irritation. Each one of these fractures, whether it was A1, A2, or A3, B1, B2, or B3, C1, C2, or C3 by AO, all these fractures of the fracture shaft of the humerus have been successfully treated with the functional brace, with the initial plaster and the functional brace after reduction. Look into the complications of the plating. And this was a Singapore-based study where 10% were non-union and osteomyelitis 1%, and shoulder and elbow stiffness 20%, and radial nerve palsy as much as 11% of patients. And look into the complications of the nailing, which is distracted, where the nail was not fixed at all. This patient came to us after nearly 7 years, mind you, 7 years, where the nail was propping out there, and the fracture finally has united. But imagine what would have happened to his supraspinatus tendon. And we just removed the nail, but he had no shoulder movement at all. Whereas, look into this case of fracture shaft of the humerus fixed with the rush nail, and that the surgeon went on till the rush nail got broken, and finally we had to fix it with a compression plate. Look into this proximal humerus. And fixed like this with 2 rush nails. And again the surgeon removes it and puts a plate. And this was the plate. The patient came after 3.5 years with the non-union of this fracture shaft of the humerus, as you see here, with the plate popping out. And what would you do? And this was she was just telling us, just give me a purposeful hand. And this was the plan of action. We just opened it up, put a large fibular graft, stud graft with the corticocancellous graft, and this was 4 months, 9 months, and 1 year follow-up, as you would appreciate. The head of the humerus and the length of the humerus and the rotational element and alignment of the humerus has been brought about, and this was the functional range after 1 year. Look into this shaft of the humerus being treated like this with a plate, and after 3 years the patient comes with this particular picture with the infection. And this was how it was. Fibula graft was put in, and this was the final picture as you would appreciate how it has come in. The next fracture which we treat every day is perhaps the lower end of the radius, which we had a discussion in the morning itself. And this picture I put it in one of the hand surgeons conference. And one surgeon said, I will put a nail, I will put a multi-log plate, and another surgeon said, I will put a just with a K-wire, and another surgeon said, I will see that the radiocarpal ligaments are sutured, which is very paramount. All we did was just to reduce the fracture. Imagine this, and that is the final picture after 6 weeks. And 12 months review, you would appreciate that the radial inclination, that the radial tilt, the length of the ulnar variance, articular stuff, everything is perfect. And there is a stable DRUJ. And this is his functional movement. Be conservative whenever possible. And these are the 8 papers which I could lay my hands upon from 2010. That the conservative line of treatment in elderly for Achilles fracture is equal to any line of type of internal fixation. Whereas if it is a fracture of this nature, of course, it has to be fixed. It has to be fragment fixed. It has to be fixed very well, both anteriorly, posteriorly, and radially. And perhaps the fracture of the scaphoid which is seen there has to be fixed well, and this is the functional range. What is to be done perfectly has to be done perfectly. And when it is not indicated, it should not be done. Here is a 48-year-old gentleman which you see here. He came from Middle East. It was operated in Middle East with an infected distal end of the radius which you see here, and this was the picture. Look into the plate which is propping out so much out, and the plate was removed, and this was the non-needed finally the patient had. And this was, we had to do an osteotomy, do an orthodesis of the wrist, and this was a 1 year follow-up, and this was a 24 months follow-up with a very good grip, and finally he was back into his job after nearly 30 painstaking months of treatment. Well, the other common dislocation which we come across, I have put in only the common things, is a dislocation of the shoulder, which is many a times is not treated properly, though it is the simplest of the treatment to be undertaken. Here is a fracture dislocation of the shoulder, which was manipulated under GA for a close reduction, and this was the picture that completely displays the patient had severe pain. Of course it has to be, this was the CT, and of course it has to be replaced, and this was the final picture. Whereas look into this, the same type of fracture dislocation, all we tried was just before we undertook surgery, we just tried to the Hippocrates style method of treatment, just put our hand into the axilla and pop, it came back into position. So it is not always what is dictum. Be innovative in your surgery. Look into that picture. Anybody, I would go and operate immediately the next day. But we just tried, just before the surgery, that manipulation, and it has come back into position. And that was the picture finally in 3 months' time. Look into this subtrochanteric fracture where there is no indication at all with this for a DHS to be put in, and automatically it broke in, and we had to put in a proximal femoral plate and the teeth, and this is the picture. Look into this unstable trochanteric fracture, fixed like this with a DHS, where there is no indication at all. And this is finally, for nearly 1.5 years, he agonized himself with this, and finally this had to be put with a nail plate, and that was the final picture. And look into this fracture neck of the femur treated like this, or nearly the fracture is united because it was an osteomyelitic fracture. And the fracture is united with a gross shortening with the neck shaft angle 90 or almost 85 degrees, and an osteotomy had to be done to correct the particular performing. And that is the final picture. Look into this, whether Shastrian classification or the loose classification, you will have to understand the fracture where the fragment is. And this was fixed like this. And this is the picture where the posterior fragment was completely neglected. We had to nearly go in after nearly 9 months, and this was the picture, and this is the final picture, what we could do. And this is the correction. Look into, many times we almost comfort ourselves with the physiotherapy. This was a supracondylar fracture, fixed like this, not a very good fixation, longer should have been the plate, and look into the medial gap. But unfortunately, he went to the physiotherapist, and the physiotherapist really manipulated in such a way that he had a periplate fracture, where he really forced. And what would you do at this particular season? Be innovative. We cannot remove that plate because the fracture has been united. So we had to really send a nail, the PFN nail, to make holes antero-posteriorly and put in a PFN nail, and see that is the picture. Antero-posteriorly we had fixed the screws, and the plate has gone, we could not remove that plate, and finally the fracture unites. Well, finally, gentlemen, I have just another 7 minutes. Here are the two great persons whom we adore in our orthopedic surgery. That is Gabriel Elizaro and Sir John Charnley. But the difference between the two, there is a subtle difference between the two. Elizaro was both an inventor and an innovator, whereas John Charnley was only an innovator. But both were perfectionists, and their contribution is immortal. And here is Elizaro's method with the non-union. In fact, the non-union, the only indication I feel is to do an Elizaro. No other method. Here is a nearly 4 centimeter shorting with an infection, and this is how it was done. And finally, this is the picture which you will see. The ankle joint is fine, and the length is very, very perfectly maintained. Finally, gentlemen, we come to little on ethics and philosophy of orthopedic practice. Apart from perfect surgery, it is also important that we follow the perfect ethics and philosophy in our everyday life. Do no harm to our own integrity and to our profession as to our patient. For I always consider we, the orthopedic surgeons, are a different band of people, are a different sect of people. We are doers, and let us practice the highest ethics. We are both physicians and surgeons. Let us undertake research. No science, medicine or agriculture, economics or veterinary physics. We the physicians, surgeons in India have miserably failed in this endeavor and wasted our large number of resources of our patients and not to be put into research. You go into the pub and you would see, out of the 4,604 articles which are reviewed on theatre, 240 on osteomyelitis, 359 on clubfoot, and 09 on neglected clubfoot. The patency rights taken by our Indian doctors was less than 0.2%. 0.2%, gentlemen. Though our clinical material is abundant, and much more than any other developed country of the world, we have failed miserably in this sector. Excuse given by our younger doctors is we have no infrastructure facility. Gentlemen, Alexander Fleming or Thomas Alva Edison or Lord Lister or Joseph Hunter did not have any advanced laboratories for their work. It was their tenacity of purpose and willpower which made them immortals. Let us come to the record keeping. Not even 1% of our doctors even today, neither hospitals, have a perfect record keeping device. To be effective leaders of tomorrow in medicine, records are vital tools. Gentlemen, we are living in an evidence-based medicine. Vaidyo Narayana Hari. We should not be haras, we should be haris. The peace and harmony and the satisfaction one derives by practicing ethical practice far surpasses the millions of rupees ill-gained by malpractice, thereby to the agony of our patients. Do your duty and leave the rest to God. The greatest of the human virtues in Aranya Parva, when Dharmaraya was advised by Yaksha, was this is the answer Dharmaraya gave Yaksha. That Dharmaraya's answer was, to be perfect, one has to overcome greed, one has to overcome jealousy, one has to overcome hatred and encompass compassion and love. At the same time, to quote the great fictional writer Sir Arthur Conan Doyle, the creator of Sherlock Holmes, who says, A physician can be the worst of the criminals, for he has the knowledge and also the means. To recall the great words of our father of nation today, the 7 deadly sins of today's world is wealth without work, enjoyment without conscience, knowledge without character, wisdom without morality. Science to us, to you and me, without humanity, and religion without sacrifice, and politics without principles as our politicians do, and finally, service without results. Let us not do any harm, but be achievers. Do no harm, at least if you cannot do any good. As leaders in our medical field, let service ennoble us. Let compassion mellow us. Let justice be the guide for all our actions. The take-home message, gentlemen, is clear. We all make mistakes. We do mistakes almost every day in our life. But to err is human, but to rectify is divine. Conservative management is still an ideal treatment option for many of our fractures and orthopedic diseases. But when surgery is indicated, plan it and execute it to perfection. To digest, the first surgery is the best surgery, and the best chance to do it well. And if you are trained, do it well. Plan your surgery well with a correct approach. Choose the right type of fixation and the implant, and have a definitive post-operative protocol, and have a team to work with you. And if there is a mistake in the initial treatment, explain it to the patient. Try to correct it at your earliest. And if one thinks he cannot do it, take your colleague's help or send it to the patient. Send the patient to the best available colleague who can rectify the mistake, who is a confidant of yours. Practice the highest principles to follow the ethics and philosophy of medical practice. Let we, the orthopedic surgeons, you and me, be the role models to our other medical fraternity. May all be
universal prayers for meditating. Om Sarve